Mercury poisoning, created by Jennifer Mishuk, a final year pharmacy student at Midwestern University. History of mercury. Mercury is a heavy metal that is widely dispersed in nature and has been used for nearly 3,000 years. In the 19th century, European occupational workers in the hat manufacturing industry suffered from chronic mercury poisoning and developed neurological symptoms, also known as erethism or Mad Hatter's disease. In 1953, a massive mercury poisoning occurred at the Minamata Bay in Japan due to the consumption of fish and shellfish contaminated with high concentrations of methylmercury, causing severe neurological disease among the residents. Mercury exists in multiple forms. As shown in the picture, mercury can be elemental, inorganic, as well as organic. The exposure and toxicity depends on the unique pharmacokinetic properties of each form. Toxicological mechanisms. Mercury forms a covalent bond with the sulfur moiety and sulfhydryl groups throughout the body, resulting in enzyme inhibition and pathological alteration of cellular membranes, structural proteins, and transport mechanisms. Elemental mercury toxicity occurs when it is oxidized to the mercurous and mercuric forms, which distribute and deposit to all tissues and the central nervous system, or CNS, resulting in multi-organ damage. Due to the lipophilic property of elemental and organic mercury, these forms significantly accumulate in the central nervous system and can cross the blood-brain barrier and placenta. In mercury salt poisoning, the mercuric ions have a direct oxidative effect on the GI tract and renal tubules, causing necrosis. Methylmercury, a form of organic mercury, causes neurocytotoxicity via oxidative damage. Elemental mercury. It is a metallic, silver-colored liquid that is also known as quicksilver. It is found in various sources, including sphygmometers, which measure blood pressure, thermometers, barometers, artisanal and illegal gold mining, as well as burning of coal and fossil fuels, and dental amalgam tooth fillings. Elemental mercury. The unique pharmacokinetic properties are shown in the table to the right. The vapor is rapidly absorbed in the lungs with poor GI and skin absorption. It is distributed in the central nervous system as well as the kidney. It is eliminated in the urine and feces with minor excretion through exhalation and skin, and the half-life is 30 to 60 days. The most common exposures are from inhaling elemental mercury vapors in occupational settings or from mishandling elemental mercury at home, such as vacuuming spilled mercury. Elemental mercury, reducing exposures. The Occupational Health and Safety Administration, or OHSA, set a permissible exposure limit of 0.1 milligrams per meters cubed during an 8-hour workday to reduce occupational exposures. Previous working conditions were as high as 0.5 milligrams per meters cubed, producing clinically significant toxic effects among the workers. Elemental mercury toxicity range. Air concentrations of 0.1 to 1 milligrams per meters cubed can produce acute toxicity. Repeated exposures to elementary mercury vapor at lower concentrations can produce chronic toxicity. Mild symptoms can occur from concentrations that are as low as 0.025 to 0.1. Exposures that are greater than 0.1 milligrams per meters cubed can cause severe symptoms. and exposures that are greater than 10 milligrams per meters cubed can be fatal. Elemental mercury, acute toxicity. This occurs within hours of inhalation. Patients start to experience symptoms that include a cough, difficulty breathing, chest pain, fever, and chills. They may also experience GI disturbances such as nausea, vomiting, and diarrhea. Other symptoms include central nervous system effects, excessive salivation, a metallic taste, gingivostomatitis, dysphagia, visual disturbances, and renal damage. The primary toxicity that is associated with acute elemental mercury poisoning is severe and potentially fatal interstitial pneumonitis and pulmonary edema. These symptoms may resolve or the patient may progress to a chronic toxicity presentation. Elemental mercury, chronic toxicity. The clinical presentation of chronic toxicity is associated with several symptoms that are shown on this slide. Erethism, also known as Mad Hatter's disease, consists of neuropsychiatric symptoms such as personality changes, delirium, insomnia, irritability, fatigue, memory loss, and hallucinations. Patients may also experience a tremor that originates in their fingers and then progresses to the movement of their limbs. Acrodynia, also known as pink disease, consists of pain in the extremities that is accompanied with pinkish discoloration and peeling on the palms and soles, as well as hypertension, profuse sweating, insomnia, irritability, anorexia, apathy, and photophobia. Another symptom that may occur is gingivostomatitis and renal dysfunction, but these symptoms are less common. Inorganic mercury. Inorganic mercury is present in various oxidation states as mercuric salts. This includes mercuric chloride, a disinfectant and pesticides, mercurous chloride, and mercuric ammonium chloride. These can be found in chlor-alkali industries, laboratory agents, cosmetic skin creams, disinfectants, and pesticides. They have also been used previously as antiseptics, antibacterials, ointments, laxatives, and anti-syphilitic agents, but these are no longer in use. Inorganic mercury. The unique pharmacokinetic parameters are shown in the table to the right. Inorganic mercury is absorbed primarily through the GI tract, but also with some absorption through the skin and mucosous membranes. It is distributed mostly to the kidney, with some transient through the blood, and delayed distribution to the central nervous system. It is eliminated primarily through the urine and feces, with minor excretion through inhalation and the skin. The half-life is 30 to 60 days. Therefore, the common exposures for inorganic mercury are in occupational settings where it is used. Inorganic mercury, toxicity range. Most inorganic mercury compounds have a lethal dose of 1 to 4 grams for a 70 kilogram adult. Mercuric chloride has a lethal dose of 1 to 2 grams, and fatalities have occurred with exposures of 0.5 grams and greater. Chronic dermal exposure can produce systemic toxicity. Weeks to years of topical skin lightening creams and/or other creams that contain 0.1 to 10% mercuric chloride have caused neurotoxicity as well as nephrotoxicity. Peritoneal lavage containing mercuric chloride with concentrations of 0.2 to 0.8% have caused severe toxicity and even death. Inorganic mercury, acute toxicity. The primary toxicity in acute presentation is GI symptoms, such as nausea, vomiting, diarrhea, as well as oral pharyngeal burns. It may also cause corrosive damage to the skin and the eyes. Some patients may have symptoms of renal insufficiency, leading to renal failure that may occur within 24 hours. Inorganic mercury, severe toxicity. The primary toxicity that's associated with this is acute tubular necrosis that can lead to renal failure. Patients may also experience a grayish discoloration of mucous membranes and metallic taste, followed by oropharyngeal pain, abdominal pain, and gingivostomatitis. Other symptoms include hemorrhagic gastroenteritis due to the corrosive effects on the GI mucosa. Massive fluid loss can lead to hypotension and shock. Aspiration of inorganic mercury can cause pneumonitis and acute lung injury. Death is due to severe GI corrosive injury, shock, cardiovascular collapse, and/or acute renal failure. Inorganic mercury, chronic toxicity. The clinical presentation of chronic toxicity includes GI symptoms, renal insufficiency, and significant neurological symptoms due to the deposition in the central nervous system with long-term exposure. Some of the neurological symptoms include tremor, erethism, and neurasthenia. Chronic exposure of mercurial powders can lead to acrodynia. Organic mercury. Organic mercury compounds can form when mercury binds to carbon. Some important examples of organic mercury are listed on the slide and organized according to their chemical structure. Aryl compounds can include the phenyl mercuric salts, which can be used as fungicides. Compounds that have short alkyl groups include methylmercury and dimethylmercury, and compounds that include long alkyl groups are thimerosal and methoxyethyl mercuric chloride. Methylmercury and dimethylmercury are the most toxic forms that we are going to discuss in more detail. Organic mercury. Elemental and inorganic mercury can also convert into methylmercury by organisms in water and soil, which can accumulate in the food chain. This is shown in the picture to the right, in which various forms of mercury can convert ultimately to methylmercury, which then results in a bioaccumulation within the fish. Human then can have exposure to methylmercury by consuming fish or seafood. Organic mercury. The main sources of organic mercury are from dietary fish consumption, placental transfer to the fetus, and trace amounts in a vaccine preservative, thimerosal. Just to note that therapeutic use of thimerosal in vaccines has not been associated with cognitive delay or any other neurotoxicity. Previous use of organic mercury included fungicides, which were banned in the 1970s, exterior paint, which has now been discontinued, antiseptics, pharmaceutical preservatives, veterinary topical antifungal and antibacterial products. Organic mercury. The unique pharmacokinetic parameters for organic mercury are shown in the table to the right. Absorption is primarily through the GI tract, but also some through the skin, oral, and respiratory. Distribution is mainly to the kidney and central nervous system, but also the blood and hair. Elimination is through the feces, and the half-life is 70 days, which you note is longer than elemental and inorganic mercury. Exposures result mostly from consuming fish contaminated with methylmercury, as well as exposure to the fetus from pregnant women with mercury poisoning. Organic mercury toxicity range. An ingestion of 10 to 60 milligrams per kilogram of methylmercury may be lethal. Repeated daily ingestions of more than 10 micrograms per kilogram may be associated with chronic symptoms. In addition, minute dermal exposures of dimethylmercury, which is highly toxic, can lead to rapidly progressive cerebral deficits, coma, and subsequent death. Organic mercury, reducing exposures. The Environmental Protection Agency, or EPA, has set standards to help reduce exposure to mercury. It recommends a maximum daily exposure to methylmercury of 0.1 micrograms per kilogram. In addition, you should limit consumption of fish containing high levels of mercury, such as swordfish, albacore tuna, to 8 to 12 ounces per week or 6 ounces per week if you are pregnant. Organic mercury toxicity. This slide displays the acute and severe clinical presentations of organic mercury poisoning. Acute toxicity includes GI symptoms such as nausea, vomiting, as well as fatigue and headaches, but is most prominently neurological toxicity. This neurological toxicity includes cognitive delays, tremor, paresthesia, ataxia, and dermatitis. In severe toxicity, the patient experiences a delayed neurotoxicity, which can occur within days to months and can be very profound and permanent. Erythema is also shown in severe toxicity. This includes sensory motor disturbances, cerebral atrophy, hearing and vision defects, blindness, dementia, paralysis, coma, and even death. Nephrotoxicity is rare. Infants that are born to women with methylmercury poisoning have developed cognitive abnormalities as well as cerebral palsy. Treatment. Confirmation of mercury exposure can be measured using 24-hour urine or whole blood mercury concentration tests. The 24-hour urine test is preferred for assessing toxicity from stable, chronic, or low-grade exposures. The whole blood test is preferred for assessing toxicity from large acute exposures. However, the whole blood test becomes less reliable as mercury redistributes to the tissues. Treatment. It is essential to remove the patient from the mercury exposure, whether that may be physically removing them from the environment, removing clothing, washing skin, or eliminating the dietary consumption of methylmercury. It is also important to provide supportive care for airway, breathing, and circulation, or ABCs. Activated charcoal is also useful for large ingestions of inorganic mercury salts consumed within 1 hour, as inorganic mercury salts have substantial adsorption to activated charcoal. Treatment. It is also important to provide oxygen, bronchodilators, and/or other pulmonary treatment for pneumonitis. Provide IV fluids and correct any electrolyte imbalances for GI fluid loss and/or hypotension. Hemodialysis may be necessary for treatment of acute renal failure caused by inorganic mercury intoxication. Chelating agents may be necessary, and these will be discussed in more detail on the following slides. Treatment. Chelating agents. Chelating agents are used for symptomatic patients with 24-hour urine or whole blood mercury concentrations that are greater than 100 micrograms per liter, or for patients with severe symptoms. The following chelating agents are used to treat mercury poisoning: Succimer, also known as DMSA, Dimercaprol, also known as BAL, and uniethyl, also known as DMPS. The chemical structures of these chelating agents are shown to the right. Treatment. Chelating agents' mechanisms of action. Orally active succimer forms stable water-soluble complexes with mercury and increases the urinary excretion of mercury. Dimercaprol has a greater affinity for mercury than the protein, which reverses enzyme inhibition by chelating the mercury and preventing or reversing its toxic effects through regeneration of free sulfhydryl groups. Uniethyl has two neighboring sulfhydryl groups which form stable mercury uniethyl complexes in the serum that are excreted into the urine via the kidneys. Treatment. Dosing for chelating agents. The specific chelating agent and the dosing depends upon the type of mercury poisoning. Succimer and dimercaprol are used for elemental and inorganic mercury poisoning, whereas uniethyl is used for organic mercury poisoning. Succimer, or DMSA, is dosed as 10 milligrams per kilogram PO by mouth 3 times a day for 5 days. Then the same dose of 10 milligrams per kilogram is administered twice a day for 14 days. Dimercaprol, or BAL, is dosed as 5 milligrams per kilogram IM or intramuscular for 1 day, and then 2.5 milligrams per kilogram IM daily or twice daily for an additional 10 days. Uniethyl, or DMPS, is dosed upon a 6-day regimen. Day 1 is 250 milligrams per kilogram IV every 3 to 4 hours. Then on day 2, it is 250 milligrams IV every 4 to 6 hours. Day 3 is 250 milligrams IV every 6 to 8 hours. Day 4 is 250 milligrams IV every 8 to 12 hours. And then days 5 and 6 is 250 milligrams every 8 to 24 hours. When to stop treatment? Treatment can be discontinued when a 24-hour mercury urine concentration is less than 20 micrograms per liter.